Good morning. Hi, everyone. I was just going to let y'all know that we are now about to get started. And here is Miss Gwen. There you go.
So should we start right on time? Okay. Well, good morning, everybody, and we will have people that are filtering in and filtering out, and my hope is that this will be an interactive session. I don't like to talk at people, and it is being live streamed, so there's a lot of virtual people that are watching, and it'll be available after the session, so there's so many good sessions that are going on right now at 10 o'clock. You'll be able to watch all of them afterward. But my name is Gwen Cooper, and I am the CEO of Accessia Health. We are one of the nonprofit patient assistance organizations in the country. This session is meaty because it's ever changing. Every 5 minutes there's some new regulation that comes out or some new topic about specialty drugs. So we're going to tackle this together. The objectives for today, you can read them on the screen, but really it's to detect the terms and types of specialty drug programs in employer-sponsored health plans. So how many of you have worked directly with employers on their specialty drugs? This is going to be an interesting topic then. For a lot of reasons, it's important for us to really start to dig into what employers are providing in their insurance benefit design programs. So identify and apply your knowledge to ask questions before patients head to the pharmacy, and define options and what these carve-outs mean for patients. So the disclaimer, it's there. These are my opinions. They're not the opinions of HAS or any of the sponsors, or NAMAPA or its affiliates or anybody else. All right, we just went through those objectives. So let's dig in. There's a big difference between fully funded healthcare plans and self-insured healthcare plans. Now, I just said fully funded and it says fully insured, or self-funded and I said self-insured. That's how confusing this the fruit salad of ABCs is in this business. It's worth it to take a minute. We've got a good solid hour, but we're going to spend a few minutes on this part of it because it's really worth it to take a look at this chart and understand what's happening. So in an employer group of about less than maybe 500 employees, you're most likely going to be fully insured. That means that your company is just going to a broker, getting your plan, setting it up, and giving it to the employees to choose. You may have a PPO, an HMO, and a high deductible plan. You're pretty much done. There's no benefit design. There's no opportunity to look at all the claims that come in. It's that you are giving your employees over to a broker that you choose to give you a plan that might be any ABC health plan insurer. The one thing on this where you look at it and it says reserves, money left over after fixed claim expense, and it says retained by the carriers. That's not always true. So as an employer, as the CEO of this company, I'm always very interested in this. One of the most unknown facts about any type of insurance plan is that the broker or the Anthems, the United Healthcares, anybody, they must spend at least 85% on healthcare claims. In some Medicaid, in some states, it might be 90%. So if there's a really good year or a year where people don't go to the doctor, think of COVID, and the plans don't spend 85% on health claims, they will give money back to the employer. So it's interesting that if you have a high claim, and this is where it becomes important, as a fully insured company, they can still come back to you the next year and say, sorry, you had some high claims, I'm going to raise your insurance rates for your employees by $1 bazillion. So in our case, one year, they came back and said, we're going to raise your claims by 30%. I'm like, no, we're a small employer, you can't do that. Well, we can do whatever we want. So we went to another insurer. In that same year where they were raising our claims, or raising our premiums at 30%, they also gave us money back. Okay, 1 + 1 does not equal 2. That's okay. On this side, the self-funded, or what I call, this is where you can get it confused, I just call you're paying all your health care yourself. So the employer is designing their plan, they're paying their health care claims, they're looking at every piece of the bottom line, they're looking at how much drug costs, we're going to get into that. But it's really important to understand the two different types of benefit designs that are out there right now. So this illustrates it a little bit better for us, and to just say, especially for purposes of our conversation, and you guys jump in anytime and ask questions, because the reason that I put this workshop together is because we started getting phone calls, like really high claims, or like what for, and for deductibles for our patients, so like what is going on. So really, fully insured and self-insured. Look at the side on the right. Where does the employer's money go? Fully insured, 100% paid to the carrier. Self-insured, pay for what you use. Remember that, pay for what you use. You're not paying for what you're not giving.
When you say self-insured, right, you also mean employee-sponsored, right?
Yes.
Thank you. I just want to be really clear on that.
Well, what do you mean by employee-sponsored?
That term is just used a lot, and I wanted to make sure we were on the same page there.
Yes.
Okay.
The reserves, I just mentioned it, profits for the carrier, maybe, if they're 85% or above. Savings for the employer, claim costs, we're just paying expenses on our side, minimum costs, the employer wants minimum costs, right? They don't want to pay, they don't want you to have a high claim, they don't want you to be sick, they want you just to show up to work. And then your fixed costs. So this is just a good way to put it in a chart to set the stage for the next part of the conversation. So believe it or not, the most recent data that I could really find was way before COVID, but 2015-16 to do some kind of a comparison, and I looked deep, and it was amazing that I couldn't find these numbers. But if you look at why larger employers will do this, look at the bottom line. You're going to save a lot of money if you take it upon yourself to design your health insurance for your employees. We'll stop there. Just see how much money you're saving. But you can see why employers are going to do this. So let's go on and bring it back to the topic. All right. We have COVID. We're still having COVID. We're still in COVID. How many years later? Let's look at some of the statistics. Before COVID, only 8% of Americans got their preventative screening. So the health care that's necessary to make sure there's nothing going on. During COVID, there is a 20% decline in oncology doctor visits. These are for people diagnosed with cancer. So during COVID, there's a 20% decline in people even going to the doctor to manage their illness. There's an 87% decrease in mammograms, 90% decrease in colonoscopies. So it is projected that this year in 2023, really even 2022, there will be a 6.2% increase in employer healthcare costs. That's just the tip of the iceberg. Now let's look at specialty drugs, because that's what we're here to talk about specifically. Only 2% of employees are on specialty drugs. It doesn't sound like a lot, but 2% of all employees in the country is a lot of people. It might not be a lot for each individual organization, but those 2% make up 51% of total prescription costs. One employee on a specialty drug could cost that employer $38,000. So keep that one statement in mind. Is it really costing the employer, or is it costing the employer and the employee? The average cost of any particular drug that is not a specialty drug is $492 a year. 75% higher costs in specialty drugs is projected over the next several years. Now let's talk about that. When I started working on this, and we're getting some phone calls, and I talk to people about what's going on in your company and tell me about their specialty drug carve-outs and all this stuff. One of the interesting comments I got back is, Why do we have to pay for specialty drugs? Why can't they just take a drug? Why can't they take a generic? Why can't, they just go get something else? And why can't they try all these different therapies and then, oh gosh, if we have to pay, we'll pay. When I hear this stuff, I just look at them and I go, so, you know anybody that has breast cancer? Well, of course I do. Okay. Do you want that person to have this general breast cancer drug, or do you want that person to have the breast cancer drug that's for the HER2 minus negative 3, 4, whatever, to beat that kind of cancer? Oh, is that what a specialty drug is? We could start so many different places in this conversation just defining things. But when we're out there and you get that phone call and you get a claim for $25,000, that patient's just upset, period, end of story. When the patient goes to the pharmacy and they're told that their deductible's $1,000, they're just upset, period, and they call you. They're not hearing anything. So the more we know and the more we understand, and the easiest way to talk about it with people, even in our general population, our general discussions, it makes a difference in education. So this is interesting. 60% of specialty drugs are billed through pharmacy benefits. 40% are billed through medical benefits. This trend is to increase the percentage of specialty drugs being billed through medical benefits is increasing. It's a whole new way for an employer and a plan and your PBMs to figure out how they are going to skin this cat. Now think about, what is a medical benefit? What is a pharmacy medical benefit? Anybody know? The easiest way I always try to explain this one is Part B. But remember, we're not talking Part B. We're not talking Medicare. We're talking employer-sponsored care. So any type of infusion, anytime the doctor touches it, means that it potentially could be billed under medical benefits. Does that fall under a carve-out? All right. There are 2,300 medications in development, with 2,000 of those being specialty medications. I would just love to change the word specialty medication to targeted therapy, period. Wouldn't that just make people think differently? I mean, it really, really would. So maybe we can start that movement. Stop talking to, we wouldn't win that battle, but we could just say, oh, you mean targeted therapy? So just come back with another word for it. All right. It is projected that there will be a 8% increase in specialty drug growth each year by 2025. So when I think 2025, I actually already go all the way right to what's 2030 look like, because some of these 2,000 drugs are going to take that long to get FDA approved. But if we're in the immediate of 2025 and you're hearing about some of the already changes in Medicare, I want you to think what's going to happen on the employer side. So with all the changes in drug pricing and what's happening on the Medicare side and capping out-of-pocket costs, et cetera, I'll move right away into where does 54% of Americans get their health care? Their employer. Of that, 46% have a high deductible plan. Can they afford their copays, their coinsurance, their cost sharing? No. It's expected that by 2030, wow, that magic number, specialty drugs will cost $1 trillion in America. So I look at everything that we do as this is an issue. We're going to talk about the issue. How do you fix this issue? We're going to just get information today and we're going to learn a little bit more about it, but I'm the policy geek in the room, and I'm like, well, how do we fix it? What do we have to do? Who do we have to talk to? And what are those solutions? And the solution, it doesn't matter if you came up with an idea or you did or I did, it's going to take every single one of us to make something change. All right, so anybody know Johnny Fever? I love this. I didn't even have to write this. I found it. So I'm like, oh, wow. And the only prescription isn't covered by my health insurance, and there's no generic due to a pharmaceutical copyright, and I feel like I'm dying. Someone help. Let's talk about specialty drug carve-outs. Just a show of hands in the room. How many of you feel like you've got a grasp on this? Okay, so if I don't, it's okay, right? It truly has been a labor of love to learn about this and talk to people, because you got to get it straight in your head. And just as late as this weekend, I was reading more articles because everybody's got an opinion. There's a lot of noise out there. And one of the things that I have learned is not only does everybody have an opinion, everybody has their own narrative. So I always tell my kids there's 3 sides to every story. Yours, mine, and the truth lies somewhere in the middle. And it's true. So I take everything in bits and pieces and then try to formulate something that makes sense. And I'm going to read you guys a couple quotes. I'll have to log into this again. All right. Look at this long list of 1, 2, 3, 4, 5, 6, 7, 8 topics. This is specialty carve-outs right here. So no wonder we're all confused. We're going to become unconfused. All right, what is nonprofit patients assistance? Everything I'm reading about under specialty carve-outs, I'm going to tell you a little story. We really wanted to learn about this, so our VP of Operations and I went to the International Federation of Employee Benefits conference to sit there and learn. What is benefit design? What is all this stuff? And this woman stood up in the room towards the end of the conference, and she labeled herself as the cost containment specialist. So I couldn't wait to hear her story. And she told everybody in the room, and these are large employers, multi-employer groups, unions, people that pay for healthcare for the employees. One guy told us that he puts $9 million away every year just to cover everything. Yeah, we learned a lot from him. It's a plumbers union in some state. She stood up there and she said, here's what I'm going to tell you guys. Carve it all out. Give it away. Give it to somebody else. Don't pay for any specialty drugs, and you will save so much money. And I went up to her afterward and I said, what do you think happens to the patient when an employer carves out the specialty drugs? Here's what she said. Do I have any pharmaceutical companies in the room? Yeah. You want to know what she said? Nothing happens to the patient. Pharmaceutical manufacturers have so much money they pay for it. Patient doesn't pay a thing, and the employer doesn't pay a thing. And I looked at her, I said, really? She goes, yeah. I said, let me tell you about the $25,000 claim that I just got. She said, what are you talking about? And I told her it was a real life story, and I told her about the patient and what happened, and we had this claim, and we wanted to figure out how to help this patient get the claim lowered so we could continue to help this patient. She said, I have never heard this before. That must be a one-off.
Should have not well.
Yeah. I said, no, I don't think it's a one-off, but maybe we could chat more. And she goes, no, I don't think so. So, nonprofit patient assistance organizations. There are 6 in the country that operate pursuant to an OIG opinion. We have 2 of my counterparts here, the Pan Foundation and Good Days in the back of the room, and then we're Accessia Health. We don't have unlimited funds. But the people that are talking about specialty carve-outs seem to think that we do. And they seem to think that if you shift the cost to a patient assistance nonprofit, that everything will be taken care of. Guess what? It's not. Because who do we largely serve? Randy? Aisha?
Medicare.
Yeah. We largely, the biggest pot of our money is Medicare beneficiaries. Why? Because pharmaceutical companies are prohibited from having a coupon program for Medicare beneficiaries. If you become Medicare eligible, and I will tell you this is the one entitlement program that I feel entitled to. I've worked since I was 15 years old. I've put money into this program. I would like to get good health care when I'm old enough to access Medicare. But does that mean I'm making more money or less money when I'm on Medicare? It probably means I'm living on much more of a fixed income, because even if I've saved my entire life, I want to live a long life after retirement, so I have to budget my money differently. So if Medicare beneficiaries, based on all of us have eligibility criteria to meet, based on FPL, based on your family, your household size, based on potentially the cost of your illness might make that FPL a little bit higher. There's all kinds of variables. And we want to help you get to the doctor, not just pay your co-pays. Well, if specialty carve-outs And the narrative on the street is, you can go to a nonprofit patient assistance organization, they will pay for it. Who is not going to get that help? Because every single one of us operates on a first come, first served basis. And the people that are designing this don't seem to understand that there's a first come, first served basis. It's not like you can just call us up and you say, my employer's not paying for this, would you just pay for it? Oh, sure, come on in. We don't have unlimited funds. What we do have is very generous donors from a wide variety of sources that understand the need. And if we could help everyone, of course we would want to help everyone, because our jobs are to be good stewards of the donor's money and stretch them as far as we can. So I don't think anybody in here needs to, I don't think I have to define what a copay assistance and a coupon program is. I think everybody in this room understands that one. All right. Accumulators and maximizers. Do y'all have this straight in your head of what they are? Okay, if I could do my own password, this is a problem when you let your computer stay too long. Sorry, I can't think and type in a password at the same time. That would be called the pregnant pause. An accumulator, I'm just going to read you this definition because I think it'll help for some of the future conversation too. Under a copay accumulator, this one's the easy one. A manufacturer copay assistance coupon does not count towards the patient's out-of-pocket costs at all. So let's say a manufacturer has a coupon program of a value of $10,000. So the patient goes to the pharmacy and they give them the coupon that they have a value of $10,000 for the year, and let's say their copay is $500, $100, or whatever. None of that is counting towards their out-of-pocket deductible. So they get to the maximum amount, and they show up at the pharmacy in what? April, May, June, July, August. All of a sudden, your copay is $500. Your copay is $1,000. And the patient had no idea. I will tell you, in defense of employers, a lot of times the employers don't have any idea. So when that patient's going back to their employer and saying, what the heck? The employer's going, I have no clue. And then they're becoming educated. In defense of employers, I will tell you that the ground is swelling and that they are all saying what's happening here. So you've got maximizers. Now the maximizer is a little bit more confusing. Under a maximizer, the full value of the manufacturer's copay program is applied evenly throughout the benefit year. Now, if it's $10,000 and that drug costs $10,000 for the year, maybe the employee doesn't have any out-of-pocket costs because it is applied evenly. And so, in my opinion, if you got to have this bad thing anyway, I'd rather be under a maximizer than an accumulator. That's not to say either one of these are good, and there are many states that are banning maximizers and accumulators from benefit design programs. For us as patient assistance organizations, those states that are banning that, if we're working on that, so what we did in Kentucky is we supported banning the accumulator maximizer programs, but we also did a separate nonprofit patient assistance bill so that the insurance companies were prohibited from denying a third-party payment. Because what's happening in the claim adjudication is we are being flagged. So we, as a patient assistance organization, are a secondary payer. We're the patient. We should be seen as the patient, and guess what? We're not. We are being seen as a pharmaceutical manufacturer copay program under patient assistance. It took me a long time to figure this out. I mean, a long time to start unraveling this, and I've talked to a whole bunch of companies. Well, we got to fix this. We've got to fix this. Because as a patient assistance organization, I should be seen as the patient. I'm getting donations and I'm paying for you. Once a donation comes into us, I'm no longer tied to that pharmaceutical manufacturer or the man on the moon or McDonald's who gave me money. I need to be seen as you, and that's not happening. big flaw in the system, and I will tell you that unraveling this and having the conversations with the companies that do the relay, that do the, you know, the highway internet, they're like, oh, they didn't know. So 80% are enrolled, 80% of all employees that receive health care from their employer are enrolled in a plan that could include an accumulator or maximizer, but 40 to 45% are affected by this. So not yet 50%, and there's a bunch of states that are working on laws to ban it. So this to me is why they're coming out with all kinds of other ways to carve out specialty drugs, because this is going to go away. There is a federal bill that somebody said is going to fix this. I've read that federal bill. I was going to bring it out and talk about it. It's not going to fix this, so it's not even worth it. So for my counterparts in the room, we can talk about it later, but the language in that bill is not going to fix this in the federal bill. All right. So let's talk about alternative funding solutions. You can call it what you want. There are a couple good actors. I will say that there are a couple companies out there that are trying to do this right and really help employers. But as you will read, overall, this is not good. And it's not good because this is in its infancy. So anytime somebody has ideas, I often say, if we could look at the healthcare system as a whole and not pick a piece here and pick a piece here and pick a piece here, we could just really take a step back and look at it as a whole, we'd be better off. But when there is a problem and somebody says, I've got the solution, that solution often comes with some unintended consequences that until they rear their ugly head, nobody realizes it. And that is policy making at its best. So when I see some of this, there are some good actors, I won't say everybody's bad, that really have the right intention. But the ones that are getting the press and the ones that show up at our door and the ones that go to the result of go to the pharmacy and cannot get their medications, those are not the good actors. All right, what is a non-health essential benefit? Anybody know? I bet you guys are not this quiet. I'm gonna go out. A non-health essential benefit, there are at least 10 non-health essential benefits that were not, there are at least 10 health benefits that were not included in the ACA as essential. Specialty drugs are not one of the 10 essential health benefits under the ACA, and so therefore they can be carved out. Do I think that when the ACA was created, anybody understood that there were going to be these wonderful targeted therapies that were going to come onto the market much quicker than anybody thought? No. So this right here is what we have to work on fixing. And there is a movement. So, since it is not an essential health benefit, there is no maximum out-of-pocket costs that are capped. What else is a non-health essential benefit under the ACA? Big one. Mental health. Mental health is not considered an essential health benefit. So then we come up with parity laws. And there are many states that have put in effect parity laws. So that if you are going to offer reproductive health, for example, you must offer the same benefit for mental health. So think about ways that we can start fixing some of this at the state level. Because if you're successful at the state level, you can be successful at the federal level. It's, you know, all ships rise with the tide. So when you have a health insurance plan and you have a pharmacy benefit, and then your employer says, well, I'm going to put this whole category of medications in the non-health essential benefit bucket. You are now uninsured. Okay, who gets to decide what formularies are not essential? Do you think the employer is saying, let me pick from column A and let me pick from column, no. It's the benefit design people, the TPAs. Now, there's a big difference between a Mercer and an Aon and a TPA. So think about it, the TPAs are even going to them and talking to them about they have this product. Why don't you offer this product to your bigger customers? Mercer, I've been meeting with them, they're shocked at some of this stuff. It's unintended consequences. It all sounds really good. And then it gets implemented in an employer plan, and then, oh my gosh, the bottom falls out. Because if you don't get your medications, and you don't fight, because maybe you're not an extrovert, and you don't feel that bad, and you don't feel like making waves, so you don't get the drug, and you stay on one that might make you feel not great, but at least it's doing something for you, what happens? You end up in the hospital. You end up at the doctor's office. You end up costing your employer more money. This whole thing is spiraling out of control. But the uninsured part is what's really interesting. So I laugh at this word, strategic advocacy. I met with this company who is a primary care provider for large employers. So they have concierge medicine. And I used to work for an organization, and we had our own primary care clinic in our company as well. And I absolutely loved it. You go to the doctor, you could take your kids, you could do whatever, they could write you scripts. Okay. So obviously it's caught on very well. This is years ago, but caught on very well. It worked for our company, and the concierge medicine provider did not want to renew the contract because they lost money. So this is years ago, and it's gotten much more sophisticated since then. But the guy I met with called it strategic advocacy, and he kept talking about pharmaceutical companies paying a certain amount per patient. Like, hey, I could get $70,000 for the drug that you're on, and then I can then negotiate it, bring it in from Canada, and it may cost $50,000, and then I get to keep the $20,000, or maybe I'll give some of that back to the employer. I said, what are you talking about? And why are you calling that strategic advocacy? Because that's what it is. I said, no, it's not. First of all, you're talking about a pharmaceutical coupon program, and it's not. If it's $70,000, then the drug must cost a whole lot of money. And what do you mean the pharmaceutical company's paying you $70,000? The whole thing blew my mind. So I laugh at the word advocacy. I said, you got to stop calling that advocacy. I don't call that advocacy. I call it, oh, I won't tell you what I said to him. I said, why are you bringing drugs in from out of the country? So a while ago, I did a little research on, in fact, it was this conference last year, we were talking about the maze of insurance. And companies will export their drugs to another country, and then bring them back in cheaper than we can get them in America, and then resell them. And that's what this guy's doing. That's illegal, kind of. It's not really, but it is. So Be Safe RX is from the FDA, and it talks about all of this. And so one of the easiest things as a patient advocate to tell your employees is go look at this website. Go see what's on there. All of us, do a little research on what that website's saying, and then ask, where's my drug coming from if you're carving me out and making me go somewhere else and sign this piece of paper that says I have to go to this company and get it. Where are you getting my drug from? Asking those questions, first of all, if the person if the company that you have to sign on the dotted line because your employer made you to get your drugs doesn't know the answer to that, I'd be running. All right, we're going to do these 4 topics. We're doing good on time?
Yeah, you're doing pretty good.
Okay. So we just talked a little bit about the importing of the drugs and rebates and coupon costs paid to the employer. Okay. The primary care clinics, assuming the costs, and then risk sharing some of them back to the employer. So to me, that's the beginning of value-based care anyway. And so now employers are getting smart. And instead of just farming out the primary care clinics or concierge medicine to another company and just paying a contract fee, they're saying, wait a second, I want to see your bottom line, and are you really saving us money? And I'd like a piece of that back. Because value-based contracting's been around for a while, but not with pharma. Now employers are going directly to their PBMs and asking for a value-based contract based on medication outcomes, which I find so interesting, don't you, our pharma company here? Because that means you have to play in adherence, which I know you want to do, but you also have to get the data back. Because who's to say it worked or it didn't work? Did you get the information from the physician? What data did the physician pull? How did they document it? Can you see the patient notes? No. Oh my gosh. So value-based contracting based on pharmaceutical outcomes, whole nother candy dish that we could play in for a really long time. And then you got the employer and employee pay. This one I find the most interesting. Because these next two slides define all the alternative funding solutions that are currently in the marketplace. And you guys will get these slides, of course. The first one, this first slide is pretty relatively easy to understand. It's the second slide and the alternative funding definition there, and then the specialty PBM carve out, where the employer point blank says, I'm not even offering it. Not going to offer it. I have another company that's going to take all of this over, and then you must, if you want drugs in any of these formularies or in this diagnosis, you have to sign on the bottom line, or we're not even going to cover you. So it's like you got one leg in being insured and one leg out being uninsured, and you don't have a choice. And you're an employee, and you don't even know what you don't know yet. You don't know what you don't have yet. You've not been diagnosed with anything yet. The whole thing is amazing. How did we not see that there could be unintended consequences here? So that brings us to, you're uninsured, and oh, by the way, your insurance plans are governed under ERISA. Is anybody in this room familiar with ERISA? Well, a really interesting place to play. But here's what I'm going to tell you as patient advocates. Know that ERISA governs employer self-insured plans. See, I get the words even in my own head screwed up sometimes. And there are rules. One of the biggest rules, treat everyone equally and fairly. Oh my. But you just carved me out because I have diabetes, or you just carved me out because I have MS, or you just carved me out because I have rheumatoid arthritis, and now I've been doing great for a couple years on my infused drug, but you just took that one drug away. And my doctor does buy and bill, and therefore can't go through your PBM that you just told me I had to sign up for, or you won't cover any of it. This is what's happening. So I was doing my research, and we were hearing these stories, and I went to my compliance officer and I said, all of this sounds really like we might have an ERISA problem. I just typed it in, and oh my gosh, a bunch of stuff came up. You're discriminating by diagnosis, which you can't do. The thing we just talked about with the data, who's sharing your data to determine why you failed on your drug or what the step therapy should be, so that the employer must pay because it won't go through the PBM, because let's go full circle, and then it comes back through 10 prior authorization conversations, and oh, we will now pay for it because we don't want you to tell us we discriminated against your disease. But it took 6 months for you to get your medication. And let's look at the claims the employer had during those 6 months. But it also has problems with taxes. And this is one I didn't think about. If employer carves out your specialty drug benefit, somehow you're on the hook for a certain amount, but the employer says, well, because I'm putting you in this PBM, we are going to write you a check for what your out-of-pocket costs were, so that we can keep all our employees on that same out-of-pocket max benefit design that we've signed up with our big broker. They're giving you a check, and that's taxable. So you do you see all the different problems that are arising out of this? So we're going to talk about, there's a few solutions. I'm going to breeze through this so we can have a little bit of a conversation. If you do cross-benefit investigation, you can then look at where are other places for me to put the cost of the medications in for my employee. What kind of adherence programs can I put in place? Am I asking the right questions, and am I going to the right people to talk about it? So it goes back to that pharmacy benefit claim versus medical benefit claim. Where is there an opportunity to do some cross billing that we might not have thought about before from the employer? Because again, the employers are not the bad guys. They are realizing we have to do something different. So we can help them do something different. We can suggest different things to them. This aggregated checklist that I found, I put this here for one reason. And it was simply to say you have the patient on one side and the employer on the other side. But in actuality, they cross. So if you think about the patient, what formulary am I on? I want to adhere to it. You could say the utilization management is the employer. But what solutions, copay solutions, etc., utilization management, claims management, they do cross. So part of being a patient advocate and being an employee and being just a patient is understanding what questions we need to ask. And what, as soon as we get our benefits, as soon as we sign up for our benefits, we are getting ready for open enrollment. So this last slide actually gives us some information to take away as some of the easiest ways for us to begin talking to our other patient advocates, our providers, our employers, and our patients. Explain to people what a drug formulary is and know and look at those formularies before you pick your insurance plans. There could be a difference in the formulary from an HMO to a PPO. Learn about the drug formularies, understand the placement of your medications, consider coupons and assistance programs, improve and expand enforcement of the parity law. Sometimes all you have to say to your employer is, really? Do you offer blah, 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 and blah, blah, blah? Then you need to offer X, Y, Z. Advocate, learn the state laws. I wouldn't expect anybody, any patients to be learning the state laws, but know who you can call. So that's where our patient advocacy groups, our patient assistance programs come in. File a complaint with state and federal agencies. You know, a complaint could be as simple as, I don't understand this law, and because of this law, my employer is doing X. It provides awareness. It just brings some issues to light. And then, of course, advocating for legislative solutions that protect consumers' rights. And that's some of the stuff that we want to do, because we want to show how are we going to take our patients' assistance dollars and spread them as far as we can, because we appreciate our donors, and the pharmaceutical companies are not the ones that should be footing the bill for all of this stuff. Because we know in this room that the specialty medications and the targeted therapies are truly what is going to improve quality of life, keep people working, and tax-paying citizens. So it benefits all of us to learn this stuff and figure out how we can talk about it together. So with that, we can open it up for questions and comments.
We have a couple questions online.
Mm-hmm.
Lauren would like to know if you can speak a little bit more about the billing under medical. She's got a little comment saying that they took it away for a little while, going to the ER to get infusions, and she wanted to know if there could be a couple of examples.
I'm not the clinical person. We don't want me even attempting to be clinical. But what I would suggest on that, and this is actually really easy, if she has to go to the emergency room to get her infusions, I would take that EOB, and I'd take the EOB from going to the medical doctor to get the infusion, walk that into HR and the CFO and go, really? We have to fix this. And that sounds so easy, but if I had a staff person that brought me that, I'd immediately be calling my broker and going, what benefits did I not know we didn't have? So I think that that's a place to start, and to get the doctor to advocate on behalf as well, but it's the plan design is what it is.
And then you have another one from Marcel. Is there a certain number of employees an employer needs to employ or self-funded plans to make sense?
The research that I have done, I was shocked that employers as small as 100 were doing their own benefit design because of the workforce that they employed. And that there is no magic number. This is where a really good qualified broker, not a TPA. TPA is a third-party administrator. You could say a broker and a TPA are the same, but in my mind, they are not. So a broker that's going to sit down and explain to you what your options are, rather sometimes than a TPA who has one product that they're trying to sell.
And we will have these slides available through email as well.
Yeah, sure, absolutely. Any other questions?
These nonprofit patient assistants are just for employee sponsored?
No, they are not. All of us are, we're a nonprofit, and our mission is to provide patient assistance to patients. Some of them are based on a specific diagnosis, or it could be based on something else. But the whole idea is that we take in donations like any other nonprofit, and we pay them out to patients that are qualified based on a set type of criteria. Yep.
So you mentioned there was a bill that's supposedly going to fix the copay accumulator program. I'm curious if there's any bills that are looking at trying to get these specialty drugs into the essential health benefits.
So there's a lot of noise. There's a lot of language floating around. The answer is probably on somebody's desk, that there might be somebody that wants to put an amendment in. We have a couple ideas of some pilot programs that we want to do to show that as a patient assistance organization, all of us can do something collectively to show how including some of this stuff would actually save costs to an employer. I'm not sure if that needs to be done at the state level or the federal level, so we're exploring those opportunities. I can do some more research and would be happy to circulate some stuff because we are looking at a lot of that. Randy, do you know of any specific piece of legislation?
I mean, I think there's different ones from different states. Like, like Chicago had the one where they're wanting to remove copays for things like insulin and those types of medications. There's nothing federal, and I do think just like these copay accumulators and enforcing health plans to take our assistance, third-party assistance, I think it's going to happen at a state level more than it is a federal.
So we're about to have an election, so there's not a lot happening right now. We are having conversations with the right lawmakers at the state and federal level, but it's all wait and see until we see. So for example, the conversations I'm having are with ranking members on either one side or the other. If the House splits, they become majority ranking members or they become minority ranking members. So when that happens, then either side gets more powerful or less powerful. So there's good conversations happening right now, but let's wait till January to really see what's going to happen. I believe that the biggest thing that we can do is that looking at healthcare as from the patient first, period. And the reason that we are having good conversations in all stakeholder groups, including elected officials, is because when we walk in the room, we are talking about the patient. We're not representing pharma. We're not representing payers. We're not representing providers. We are representing the patient, and we're bringing real world stories to say this is what's happening. And it's not just with these high priced diseases. It's with diabetes. It's with this. It's with that. And then we can give the right information based on the patient experience. And that's what seems to be moving the needle a little bit, to have good quality conversations. Well, thank you. Enjoy the conference, and I'll be here if anybody has any questions.
I was for Jen. It's a Bible. We are actually putting together a patient support program.
Oh, good. We should chat.
Yes. I was going to reach out to you guys on the app. Yeah, so my colleague Wendy, she's working on this strategy. I'm also the special manager. Did you guys work with real endpoints? Do you know who they are? Real endpoints? They have, like our health responding, website, so we, yeah, yeah. We're gonna partner with them, so that when the patients go to our center, they can direct them to the, database that they have for the professional.
Oh, great, 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 great. What,